to another lower limb Viva. Hi, Walid, are you ready?
Yes, I am.
Great. So you've been called to see this 26-year-old gentleman who came into the resus. He sustained a road traffic accident, motorbike versus car that was driving at 60 miles per hour. His knee is swollen and deformed, so they got an X-ray. Have a look and tell me what you see.
So this is an AP X-ray of a slightly mature patient. I can see a fracture of the tibial plateau, a Chatzker type 4, and with that I can see subluxation of the knee. So basically this would be a fracture dislocation of the knee. These cases are high energy injuries, and they are associated with a high incidence of neurovascular injury. I would examine him using the ATLS protocol. I would take ample history. I would be more concerned about the pulse. I would aim to get the knee reduced in the first instance. I would use sedation in the A&E and aim to reduce it in an above knee backslab following the reduction.
You did that successfully. It's an isolated injury. He's neurovascularly intact. He's generally fit and well. You manipulated the knee, you aligned it nicely, and you've applied the backslab. It seems to be still unstable. What are you planning to do next?
Yes, so first I would obtain a CT angiogram.
Why is that? The pulse is intact.
So because these injuries have an incidence of intimal tears, so he might have an intact pulse, but he might have a subtle intimal tear in the popliteal artery.
Okay, you've obtained the CT angio. Here it is.
Yeah. So yeah, so from the CT angio, it looks like he has good distal perfusion. From the CT scan, it basically confirms what I could see on the X-ray. So he's got a medial fragment. There's some comminution in the plateau. Yes.
Okay.
So if the knee is unstable in this condition and I can't get a good reduction, then my next management would be to take him to the theaters and probably put an external fixator on. It would give me a better reduction and give me time for give me a chance for the soft tissue swelling to subside.
Okay.
And I would be less concerned about vascular injury meanwhile. The step after that is if I haven't had the CT scan, I would do the CT scan, and then I would plan for fixation after that. So
tell me about what will you fix and how will you achieve that?
So I am aware that these injuries or these types of fractures, they might have a soft tissue component, particularly the posterolateral corner involvement and the LCL. However, I would aim to address the bony injury in the first instance. I would, given that the injury is medial, I would aim for a medial buttressing plate, and I would aim for anatomical reduction, given that this is an articular fracture. Following the reduction, I would put him in a hinged knee brace with a range of motion from 0 to 90 degrees. I would advocate, maybe initially I would limit it until soft tissue healing, maybe to around 0 to 40, but then after I remove the sutures, I could go for 0 to 90 degrees. I would follow this up until bone healing, and around 6 weeks, I would re-examine the knee once again to look and see if there's any signs of residual knee instability, with special emphasis on the LCL posterolateral corners and the.
Okay. So what if the bone starts to heal well? He's doing okay in terms of bone healing. However, you find that the posterolateral corner is unstable. So by examination, he's got a posterolateral corner injury.
Yes. So this is a 26-year-old, clearly fit and well gentleman. So in this case, I would then discuss a reconstruction of the injured ligaments. The sooner would be the better, as soon as I have achieved bone healing. Thank you. Do you think? Okay.
Thanks. So, well done, Waleed. What do you think? How do you think the Viva went?
I think it went well. I'm more used to, or I was more expecting more of a Chatsker 2 or 3, which we see more commonly, but this was a Chatsker 4 with an element of knee subluxation. So it sort of, I was between, my mind was struggling between the knee dislocation component and between the tibial plateau component, but I think I managed to cover both aspects. The knee dislocation aspect and the tibial plateau aspect.
I think absolutely, I totally agree. You demonstrated high level of competence in dealing with those injuries. You know the knowledge. You're aware that this is a high energy injury. You're aware that there is a bony component and there could be a soft tissue injury as well. You are aware that you still need to obtain CT angiogram even if the pulse is intact. Because of the fact that there is a high incidence of intimal tears that could be missed and can lead to pseudoaneurysms later on. In the initial management, you have aligned it nicely in a back slab, but you're aware that if it's grossly unstable, you will need to apply an X-fix in the acute setting until you plan for definitive fixation. You're aware of the concepts for definitive fixation, the AO concepts for anatomic reduction, absolute stability, and how to address the medial fragment with a buttress plate. The correct buzzword, you've pressed on it using a buttress plate. Whether it's a locked plate or a regular plate, that doesn't matter, but the concept is there. And then you're aware that down the line, you need to assess the ligamentous stability of the knee. Once the bone have started to heal, you will allow the range of motion. I think you've covered it really nicely and very smoothly. You've been able to sail through the Viva to a straight 7, I think.
Okay, thank you, Viga.